the JST faculty. So this is done every Saturday, 9 to 10 a.m. If you want to join Jaipur Surgical Tutorial, in between the sessions, I will project a slide which will show you how to do that. You can send a WhatsApp message to Dr. Anand Nagar, and then he will add on your name and your contact details to the Jaipur Surgical Tutorial group, which already has more than 500 members, including faculty and students. Then sometime last year, we started these master classes, which are once in a month, and now they will be held every Wednesday and Thursday, last Wednesday and Thursday of the month, so that we don't clash with the IASG Friday evening academic activity. These are done 7 p.m. to 9 p.m. India time. We select one topic or one theme, and then we invite colleagues from all over the country to contribute. Usually we have 3 presentations on each day, which are half an hour. So the speaker gets about 15 minutes. The moderators have 5 minutes to make comments, and 10 minutes are for question and answer. I would request the moderators that if there are no questions, the questions will come on the YouTube where the delegates are watching this, which I will transmit to the moderators. But if there are no questions from the students, I request the moderators to generate their own questions and carry on the discussion. All the previous master classes, 13 master classes, and all the more than 200 video recordings of the Jaipur Surgical Tutorial sessions are available on the YouTube. All this technical support is provided by the team of my former student and now a colleague, Dr. Avinash Nak at Dwarika Clinic in Ahmedabad. So if you go to YouTube and put Gastro University, which is the name of the online portal which Avinash has started, you will get to the previously recorded videos of all the master classes, all the Jaipur Surgical Tutorial classes, and also the 3 Jaipur Surgical festivals that we have held in the last 3 years. I will make an announcement about a 4th one also, which is going to be held in December this year, and an IASGO postgraduate course on jaundice. So all this educational material is available for free on YouTube for any of the students. So today's theme is carcinoma of the rectum. And to moderate this session, I have invited 2 of my colleagues, Dr. Ram Daga, who was a fellow with us at SGPGI, but now he is a colleague. He is the head of the Department of Surgical Gastroenterology at the SMS College in Jaipur, one of the largest and one of the oldest medical schools in the country. And Deeksha Kapoor, who is a consultant GI surgeon at BLK Max, where she shifted recently from Vedanta, where she had a long innings. And it's very happy to see that today's masterclass is seeing the girl power. We have Deeksha, we have Sharvari, we have Sanyukta. So Deeksha and Sharvari are role models for girls who are doing surgery and who want to do GI and HPB surgery. So with that brief overview, I would hand over to Ram and Deeksha to continue to moderate the session.
Yeah, thank you, sir. So today we are having session on carcinoma rectum, and our first speaker is Dr. Sharvari Pujari. She is from KM Mumbai, and she will speak on surgical anatomy of rectum. Over to you, Sharvari.
Thank you, Dr. Kapoor, sir. Thank you, Dr. Ram, and hi, Deeksha. My screen is visible?
Yeah.
So I will be talking on the surgical anatomy of rectum with relevance to especially carcinoma of rectum. So the rectum extends from rectosigmoid junction to the anorectal ring. Intraoperatively, the upper margin of rectum can be identified as the level where tinea coli of sigmoid colon diffuse to form a longitudinal layer of rectum and epiploic appendices disappear. This corresponds to the level of about 12 to 15 centimeter from the anal verge, and in the sacrum, it corresponds to about sacral promontory, that is the level of S1 to up to S3 level. It extends from the lower margin of anorectal ring, which is the where the levator ani, all the muscles which form the levator ani, that is the pubococcygeus, iliococcygeus, and puborectalis, merge to form the sphincter complex of the anal canal. That is the lowermost extent of the rectum. So there are some important landmarks when the rectum anatomy is considered. It is considered to be divided into three parts. So if we consider anal canal length as 4 centimeters, then above that in the cranial direction, up to 8 centimeters is the lower third of rectum, from 8 to 12 is the middle third, and from 12 to 16 is the upper third of rectum. It has 3 curves, 2 convex on the right side and middle 1 convex on the left side. These are important for insertion of the scope. When the scope is inserted, most important or prominent thing which is seen first is the presence of Houston's valves, which are the horizontal semilunar permanent mucosal folds in the lumen, which correspond to the concavity of the curves. So on digital rectal examination, if we consider our length of finger is about 7.5 to 8 centimeter, then it reaches up to middle third of the rectum. Whereas the standard proctoscope, which has the length of 13 centimeter, will show upper part of rectum also. It is also important to know relevant anatomy of the anal canal, as it lies in very much approximation, and it is very much important when the cancer is involved in the lower third of the rectum. So at the anorectal junction, the rectum ends and the anal canal starts. Thereafter, there lies a zone of anal transition zone, and there are the anal columns of the anal glands and the mucosal folds, at the end of which there is the dentate line. So the surgical anal canal, or the anal canal, what surgeons consider, extends from the dentate line to anal verge, whereas the anatomist consider it as from anorectal junction to anal verge. Now coming to peritoneal reflections. The rectum is covered with the peritoneum. In the upper 1/3, the peritoneum is covered anteriorly and laterally. In the middle third, however, it is covered only anteriorly, and the lower third is completely devoid of peritoneum, or it is extraperitoneal. The location of peritoneal reflection, so the peritoneum which comes in front of the rectum gets reflected on its own, and it is known as peritoneal reflection, and this level corresponds to up to about 6 to 9 centimeters from the anal verge. It corresponds to the middle rectal valve, and it is the important landmark as far as resection anastomosis in these regions are considered. Broadly speaking, whatever resection and anastomosis is done above this level of peritoneal reflection is called as anterior resection. Anything below the level of peritoneal reflection is called as low anterior resection. And if the anastomosis go below the level of anorectal ring, then it becomes the ultra low anterior resection. Also, the importance of these rectal divisions is because the upper rectum, oncologically upper third of the rectum, which is intraperitoneal, oncologically behaves like carcinoma rectum. So it is also treated like carcinoma rectum, broadly considering as broadly it can be remembered as upfront surgery is done when the carcinoma is involving upper rectum. Whereas
sorry to interrupt, you meant carcinoma, it behaves like carcinoma of the colon.
Yes, carcinoma of the colon, sigmoid colon.
Yes.
This is in broad terms. When there is an upper rectal or at the rectosigmoid junction, upfront surgery can be considered like we consider in the case of CA colon. When the cancer is in the extraperitoneal part of the rectum, however, because there is no peritoneal covering, the tumors tend to be more aggressive, invade mesorectum more aggressively, and surrounding structures also. These tumors are bulky, and so these require neoadjuvant chemoradiotherapy as in broad terms, which we will discuss later on at various levels what is to be done. But if it is in the middle, if it is below the level of peritoneal reflection, neoadjuvant chemoradiotherapy comes before the surgery when the management is considered. Also, for the lower third or the distal most rectal cancers comes the importance of sphincters of anal canal, because it is in the close proximation of the sphincters. So here the sphincter saving becomes important consideration, and it is possible only if the lower edge of the tumor is more than 3 centimeter above the anorectal ring. This is because 2 centimeter distal mural margin is considered adequate when rectal resections are done for rectal cancer. When there is neoadjuvant chemoradiotherapy is given, 1 centimeter margin is considered adequate. However, this 1 or 2 centimeter is achieved only if the tumor is above at least 3 centimeters the anorectal ring. Now coming to mesorectum. This is an important structure. It is the fibrofatty tissue that contains the rectal vessels, nerves, and lymph nodes. Posterior to the rectum, the mesorectum lies majoritarily on the posterior side, but it extends laterally also and includes about 3/4 of the circumference of the rectum. And in the most distal parts of the rectum, the mesorectum disappears. The mesorectum is covered by the fascia propria of the rectum, or the visceral fascia, what we can also call it as. Importance of the mesorectum is that the oncological plane of dissection while doing surgical surgery for rectal cancer should lie outside the fascia propria, preserving intact mesorectum. Means we have to resect the rectum, mesorectum as an intact unit, with the plane of dissection being outside the mesorectal fascia, the fascia propria. Now coming to these facial relationships. So the fascia propria is the fascia which covers the mesorectum. The parietal pelvic fascia covers the bony pelvis and covers the sacrum, coccyx, and muscles of the pelvic side walls, and so it covers the presacral veins. It is the lateral most structure in the pelvis. These two fascia fuse posteriorly at the level of S4 to form the rectosacral fascia, which needs division in the low anterior resection surgery. Whereas anteriorly, this visceral fascia is reflected on the prostate as a denonvillous fascia in men, or as a rectovaginal fascia in females. These visceral and parietal endopelvic fascia can be considered as downward extensions from the abdomen. So the visceral fascia is the one which is lying anterior to the vessels, retroperitoneal vessels, that is aorta and vena cava, and then it extends in the pelvis and envelopes the rectum and becomes visceral endopelvic fascia. Whereas the parietal fascia is the one which lies posterior in the abdomen, posterior to the vessels, aorta and cava, and thus runs along the pelvic wall and covers the bony pelvis and the muscles of pelvis. So there is a potential space which lies in between these two fascia, which is devoid of any neurovascular tissue, but it is only filled with loose areolar tissue, and this is the important plane which is described as holy plane of Head, which is of the utmost importance in the total mesorectal excision. Now, below the level of peritoneal reflection, rectum is supported by the lateral rectal ligaments. These lateral rectal ligaments are the extraperitoneal thick bundle of dense connective tissue, and in this lateral rectal ligaments, they contribute to the support of the rectum, and so they also contain some branches of middle hepatic artery. The main middle hepatic artery usually doesn't travel through the lateral rectal ligaments, but there are branches of middle hemorrhoidal artery, lymphatics, and plexuses. At the lateral most part of these lateral rectal ligaments lies near the pelvic walls, and so beneath these lies the pelvic plexus of autonomic nerves. So without injuring these pelvic plexus, these lateral rectal ligaments should be divided sharply and need ligation, because vessels are there and they bleed. And one more important thing is, once these ligaments are divided, it straightens up the rectum, and complete mobilization of lateral rectal ligaments leads to addition of length of about 2 centimeters. So if there is a tumor situated in this crucial position where length distal margin is an issue, then lateral rectal ligament division may shift the tumor little upwards, that is about 2 centimeter upwards, and that much length and the distal margin can be achieved. Now coming to blood supply of the rectum. Rectum is supplied superiorly by the superior rectal artery, which comes from the inferior mesenteric artery branch of aorta. Middle rectal artery arises from the internal iliac artery, supplying the middle and lower part of the rectum, and inferior rectal artery arises from the internal pudendal artery. Similarly, the veins, the superior rectal vein drains into the inferior mesenteric vein and to the portal vein, which drains the upper and middle part of the rectum. Middle rectal vein will go to internal iliac vein and then to the systemic part, that is the IVC. So these portal vein and IVC communication become important part of portovenous communication site when the portal hypertension, when the patient is a case of portal hypertension. Inferior rectal vein drains to the pudendal vein, and that also drains the part of the anal canal. Now coming to lymphatic drainage. Upper and middle part of the rectum clearly drains from the via the nodes along the superior rectal vessels to the first to the pararectal nodes and then to the inferior mesenteric nodes. What happens below the level of peritoneal reflection is that it has a dual lymphatic drainage. So below this level, majoritarily it drains upwards, that is along the superior rectal artery to IMA and para-aortic nodes. However, some part also drains laterally, goes in the lateral direction along the middle and inferior rectal artery, and then go to the internal and external iliac group of lymph nodes. And below the dentate line, it goes to inguinal group of lymph nodes. So why this is important? Because the internal iliac lymph node, these are the pararectal nodes, these are the internal iliac, this is the obturator, these are the external iliac and common iliac group of lymph nodes. So there is no doubt about the internal iliac group of lymph nodes. These are considered as regional disease and will be resected in the standard resections. However, this external group of lymph nodes near the external iliac, common carotid and obturator are considered as metastatic group of lymph nodes according to the Western concept, and TNM also considered it as metastatic, whereas Japanese people consider the same as regional only. So they advocate lateral lymph node dissection. However, in the TNM guidelines, this is to be treated with the chemoradiotherapy and radiotherapy to the lymph nodes. So this group of lymph nodes, which is the common iliac group of lymph nodes, station 273. This is the internal iliac, 263 station, and 283, that is the obturator in between the internal and external iliac vessels is the obturator group of lymph nodes, and this group of lymph nodes is called as lateral lymph nodes or lateral pelvic lymph nodes, and the dissection of lateral pelvic lymph nodes during standard rectal carcinoma surgeries is a matter of debate. As I said, majority of the lymph node metastasis, that is up to 40%, goes to superior group of lymph nodes, and only 15% of the times these lateral lymph nodes are involved. But the advantages of lateral lymph node dissection is proposed that it decreases the intrapelvic recurrence by 5% and improves 5-year survival by 8 to 9%. However, the opponents say that as it is involved in only small percentage of cases, why to add the operative time and thus put the patient to higher morbidity. Besides this, they consider lateral lymph node involvement of lateral group of pelvic lymph nodes is the indicative of systemic disease. Now coming to nerve supply. The rectum has both sympathetic and parasympathetic nerve supply. The sympathetic comes from the lumbar splanchnic, which is responsible for relaxation of, in broad terms, it is responsible for rectal muscle relaxation and contraction of sphincters, whereas parasympathetic allows stools to pass, that is contraction of rectal walls and relaxation of internal anal sphincter. Besides this, some important things, some important plexuses which are there in this region are the superior hypogastric plexus and inferior hypogastric plexus. So superior hypogastric plexus arises near the aortic bifurcation and near the origin of inferior mesenteric artery. It contains the sympathetic fibers majoritarily. The lowermost extension of the superior hypogastric plexus descends down as hypogastric nerves, and then it goes into the pelvis. So high IMA ligation or ligation of IMA flush to the aorta leads to damaging of the superior hypogastric plexus. And whereas when the dissection is there in the pelvis, the pelvic plexus, which is also called as inferior hypogastric plexus, is encountered. It is present along the lateral walls of the pelvis, and it gives fan-shaped fibers to innervate the urogenital organs. It contains both sympathetic and parasympathetic fibers. So this is the IVC and aorta, and in front of L3 originates the superior hypogastric plexus with its ganglion, and then it descends down in the near or lateral to the aorta, and this is the origin of IMA. So when the IMA is ligated and divided flush to aorta, there is a chance of injuring the superior hypogastric plexus. When it descends down in the pelvis, they become hypogastric nerves. These are the hypogastric nerves on the right and left side. These are lateral to the midline and medial to the ureters, which cross the iliac vessels. So our dissection should be medial to the hypogastric nerves, pushing all the structures of hypogastric nerves, ureter and iliac vessels posteriorly and laterally without injuring them. So as I said, the hypogastric nerves descend in the pelvis and ureters cross over the iliac vessels but lie lateral to the hypogastric nerves on either sides. So the inferior hypogastric plexus lies on the pelvic side walls and then gives fibers to the urogenital organs. This is the plexus of the uterus, going to the uterus, and then the nerve to the urinary sphincter. The nerve to urinary sphincter arises in the groove between the rectum and levator ani muscle at the level of pelvic floor, and is likely to get injured when the levator ani is divided during APR. So once again, I am repeating, this is the ligating IMA pedicle, and this is the superior hypogastric plexus. This is the mesorectum. These are the hypogastric nerves, and this is the pre-hypogastric nerve fascia. So the dissection should be just behind the rectum, pushing this fascia and nerves posteriorly. On the right side, it should be in the triangular area anterolateral to the right hypogastric nerve towards the mesorectum, and not here. This star area, the dissection should not go in this region on the right side. In the inferior, so the inferior hypogastric and plexus and the nerves are preserved, and anteriorly it should be, the neurovascular bundle should be pushed anteriorly towards the prostate. I would like to show the same in this small video. I'm sure it will be also talked about during the surgical session tomorrow. But this is during the dissection of aorta, this IMA is lifted up, laparoscopic LAR is being done, and this is the nerve plexus, superior hypogastric nerve plexus lying on the aorta, and so the IMA is divided approximately 1.5 to 2 centimeters beyond its origin. This is in the region of hypogastric nerves. The dissection is being done in the pelvis, and the hypogastric nerves will be lying posterior. This is the mesorectum, and this should be the line of dissection, pushing the nerves behind. When the dissection is on the lateral wall, this is the left side of the dissection. This is near the pelvic wall, but without injuring the pelvic plexus lying here. And then the dissection is continued anteriorly. And the pelvic plexus, you can see here the nerves of the pelvic plexus running laterally on the pelvic wall and giving fibers in the fan-shaped manner and then running towards the bladder and the genital organs. In the anterior, this is the on the right side, this is the right hypogastric nerve, which I showed you in the picture. This is the nerve, and if there is excessive traction, the nerve gets tented and it gets pulled towards the mesorectum. However, and then there is a chance of injury to the right hypogastric nerve and the plexus. So, but there lies a triangular area, and the dissection should be pushing the nerve and plexus laterally, like this. This is the right hypogastric nerve, and the line of dissection should go just near the mesorectum. And then this is the anterior dissection. If the tumor is placed anteriorly on the rectum, it becomes more difficult to push the neurovascular bundle anteriorly from the Denon-Wheeler's fascia. As Denon-Wheeler's fascia is open, and the neurovascular bundle is pushed in all cases. But if the tumor is placed anteriorly, there is high chance that the injury may happen. This is at the level of pelvic floor. So these are the 4 important sites where there is the likelihood of nerve injury. So if there is injury of the superior hypogastric plexus, the symptoms can be retrograde ejaculation and dyspareunia, because majority of the nerves are sympathetic. So parasympathetic overactivity will happen. In the hypogastric nerve is injured, if the hypogastric nerve is injured, there will be symptoms of urinary problems in the form of neurogenic incontinence or atonic bladder. In the case of inferior hepatic plexus injury, impotence will be there and urinary dysfunction. Here the parasympathetic nerves are will get injured, and it will lead to erectile dysfunction. Whereas if the nervy irrigants are injured, again there will be voiding issues or impaired vaginal lubrication. Now coming to in short about the TME, something about TME. So the TME is the removal, total mesorectal excision is the removal of entire mesorectum, including posterior and portion distal to the tumor, keeping intact, keeping the fascia intact. It should be in correct plane, that is the holy plane. There should be sharp dissection, intact mesorectum, and 5 centimeter distal to the tumor margin. The mesorectum is supposed to be resected, with distal mural margin is advised is 1 centimeter at least, and the CRM should be at least 1 millimeter. So what is the CRM? It is a circumferential resection margin, which is the non-peritonealized surface of the rectal specimen created after mesorectal dissection. This is the main cause of local recurrence when the CRM is positive. And if it is considered positive, if it is less than 1 millimeter, that means the distance of the tumor or the tumor deposit, the distance from that margin to the closest margin of the surgical resection, non-peritonealized resection margin, is considered as circumferential rectal margin, and it should be at least 1 millimeter or more. If it is less than 1, there is enough literature to suggest that if there is a less than 1 millimeter margin, the local recurrence rate is very high. It goes up to 22% compared with only 5% if the margin is more than 1 millimeter. And also if margin is positive, along with local recurrence is also there is also increased risk of distant metastasis and shorter survival. Coming to surgical options of rectal cancer, when there is upper third, it is clear that anterior resection can be done. When it is the lower third, below the level of peritoneal reflection, then it is called as low anterior resection. The anastomosis goes below the level of peritoneal reflection. And for the lower third, there are a few more options depending upon the Ruhlier's classification. So low anterior resection is possible if the tumor is located 5 centimeter or more from the dentate line, so that at least 1 to 2 centimeter distal margin is achievable, and the anastomosis will be colorectal anastomosis done by double staple technique. If the tumor is further below, that is within 1 to 2 centimeters of the dentate line, then only then the appropriate margin will be reached only if the anastomosis is done at the level of anorectal ring, where the anastomosis then will be colo-anal anastomosis. Colon to anal canal anastomosis will be there, which may require hand seven anastomosis, and then it is called as ultra low resection. If the tumor is further below this level, which involves the internal anal sphincter but spares the external anal sphincter, then we need to resect the internal anal sphincter either in, so it is called as intersphincteric resection, and it can be a partial intersphincteric resection, subtotal or total, depending upon the level of involvement. Upper 1/3 up to 2/3 of the internal sphincter is resected in the subtotal, and complete resection of internal anal sphincter in the intersphincteric groove is done if we have to do a total intersphincteric resection. Now, if the tumor is involving the external anal sphincter also, then both the internal and external anal sphincters are supposed to be excised, and then the patient becomes a candidate for abdominoperineal resection. The sphincter cannot be saved, and patient has to undergo abdominoperineal resection. Conventional abdominoperineal resection was used to be done like this without taking the levator. So the specimen used to be conical in shape with a vest lying at the tumor level, increasing the chance of CRM positivity. So extra levator APR should be done, which removes APR also, giving a cylindrical type of specimen and minimizing the chance of CRM positivity, and even further modifications of this in the form of unilateral hemi levator ani resection or many things like this are described. Thus, to conclude, the rectum has the dual arterial blood supply, dual venous drainage, extensive lymphatic drainage. It is located in the, in fact, 3 arteries, 3 veins, and the dual lymphatic drainage. It is located in the bony pelvis surrounding the various important urogenital and neurovascular structures. The surgical treatment of the rectum is challenging, which is the total mesorectal excision as the standard of care. And to achieve this, good and thorough knowledge of the surgical anatomy of rectum is of paramount importance. Thank you.
Before I hand over to the moderators, there's a question on YouTube, although it's not related to topic, but Sharvari, if you can quickly answer this. Himanshu Mishra wants to know, while doing pouch surgery for ulcerative colitis, what is the level of distal transaction of rectum? Is it the levator ani level or is it dentate line?
The pouch surgery, Himanshu, the pouch surgery itself describes the name. The name of the pouch surgery is ileal pouch anal anastomosis. So the entire rectum, it is done for the ulcerative colitis. So when the rectum is involved, and usually it is involved in the ulcerative colitis, so the entire diseased portion of the rectum is supposed to get resected. Here we do not resect the anal transition zone, but do the anastomosis just above the level of anal transition zone, that is at the anorectal ring level, and it will be a ileal pouch to anal anastomosis, keeping sphincters intact.
Over to you, Ram and Deeksha.
Dr. Sharvari, thank you. That was a brilliant talk. I think you covered all aspects of the surgical anatomy of rectum very relevantly. Before I pick up a few questions with you, I really want to thank Dr. Kapoor, sir, for involving me once again for the master classes. It's always a privilege, and you've always been very kind and encouraging. So just to add to Himanshu's question, when we are dissecting from above and from inside, the landmark is the pelvic floor or the levator ani muscles, where they start becoming vertical. And when we are doing a perrectal from inside or visualizing the disease from inside, it is the dentate line. Actually, it almost coincides by hardly any difference. So it's probably one or the same things. Sharvari, I want to ask you that during surgery, how does a beginner differentiate between the fascia between the various layers of the TME while doing the TME?
Okay. So if the TME in the open as well as in the laparoscopy, I will describe it more in the TME, laparoscopic low anterior resection. So when you lift up the colon, you retract the sigmoid colon and lift up the rectum, the plane which is there can be seen as a white line, and if you are in the correct plane and if there is incorrect insufflation, then the planes get clearly defined when the gas goes in. But if there is no laparoscopic surgery, if it is an open surgery and the rectum is retracted, and so it is a matter of proper retraction and finding the plane. So if the rectum is pulled anteriorly and superiorly, then behind the rectum and mesorectum, just in front of the vessels, we get a plane. When we start the surgery for rectal cancer, we usually start at the level of IMA. So a vascular pedicle gets lifted up and becomes taut and looks like a cord-like structure where we can identify the inferior mesenteric artery and vessel. And the plane below that, the level below that, if we start dissecting, then we are actually in the proper plane, which is confirmed from the other side also. From the lateral side, it starts from the division, after the division of ligament line of Told.
Yes, that's very beautifully described, Dr. Sharvari. I just want to add to it that when we pinch at the sacral promontory and just lift the rectosigmoid junction superiorly to the left and towards the anterior abdominal wall end of the patient, and just with a little bit of scoring on the peritoneal surface, a shiny sheath gets separated towards the side of the mesorectum. One sheath gets left behind, and there is a crisscrossing of fibers which need to be divided. So if the fat is being breached, that means we are too much towards the rectum. The fat should belong to the rectum. So that's, I think, one point that we need to emphasize on surgical anatomy and the surgical technique, that the fat always belongs to the rectum.
Yes.
Dr. Ram, you want to add something to this?
I would like to ask a question.
Yeah, please.
Yeah. So what are the importance of these various fascia? Walden's fascia, rectosacral fascia, lateral ligament, condensation of these fascia? What is the importance on surgical table as such? How they make your surgery difficult or easy, or in what way they change your surgical plans?
Yes, so the basic for the total mesorectal excision, we have to identify the visceral fascia or the fascia propria, and it has to come along with the mesorectum, and our plane should be behind that. Then only we will enter, as we discussed just now, into the plane of holy plane of head, where there will be no neurovascular structures. Another important thing is that we don't have to breach the fascia which lies behind that, because it is the presacral fascia, and behind the presacral fascia will be the neurovascular bundle. There will be presacral veins which will bleed terribly, and which will be very difficult to control the bleeding from the presacral veins, because these are the veins which come from the sacral foramina, and they bleed and they get retracted inside the sacral foramina. So important thing is not to breach the presacral fascia, which is covering all these structures. Now these two fascia, when we go below and below at the level of S4 and coccyx level, form the rectosacral ligament, and that needs to be divided if our dissection goes there sharply. Division of coccyx or excision of coccyx may or may not be done, but division of the rectosacral ligament is a must if the surgery is in the low AR or ultra low AR region. Anteriorly, the fascias are important because it is the facial reflection on the prostate or the in the females rectovaginal septum. So the dissection should, the denonvillous fascia should be opened. The fascia should come with the rectum. However, the neurovascular, again the venous plexus which lies below the covering, the fascia is covering the venous plexus, and that should not be breached. So even in some cases, if the lesion is posterior, or if the lesion is little higher up, then even Denon-Wheeler's fascia can be left behind the prostatic venous plexus. But if it is required to be excised, then the venous plexus must be taken care of, must not be injured.
I think we'll move on.
Beautifully explained to residents.
Besides
Yes,
this, whenever there is anastomotic,
Please carry on. Please carry on.
so I would
besides
just
this,
like to add on
in
a
any
point.
other,
Yeah.
No, Sharvari first. Yes.
besides this, in the case of any benign diseases, or if there is a rectal perforation, or if there is a rectal leak, if it is in the extraperitoneal region, then it can be managed extraperitoneally from the perineal side. If it need not be there need not be any the laparotomy if the perforation is in the extraperitoneal region. It remains contained in the extraperitoneal region, and the peritoneum is clean if there is a small leak or perforation in the extraperitoneal side.
I
Ram,
think
any concluding remark?
yes, sir. I think beautifully explained, sir. I think we can move to next session.
I'll introduce the next speaker. Next speaker is Sanyukta. She is my colleague at Mahatma Gandhi Hospital in the Department of Radiology, and she has special interest in MR imaging. She is currently in the UK doing a fellowship and probably preparing for her FRCR examination. So she's going to cover the radiological aspects of CA rectum. Sanyukta.
Thank you, sir. I will just share my screen. Good evening, everyone. Thank you so much, Dr. Kapoor, sir, for giving me an opportunity.
Please convert it to a slideshow.
Yeah. Okay. Yes, sir.
Please carry on.
Yes. Thank you, sir, for giving me this opportunity. And assuming that I'm the junior most here, I'm very honored to be part of this team. And let's continue with the lecture. So we're talking about the imaging aspects of carcinoma rectum. And being a radiologist, I'll be talking about just an overview. I'll be first talking about the MRI protocol. When can the clinician send a person for a MRI if he's suspecting a CA rectum? What are the relevant anatomy on MRI, how to identify? And to stage the rectal CA, the restaging of rectal CA post NACT, which has also assumed a major role. The reporting templates we advise and we follow. I hope I'm audible.
Yes, please
Yes.
carry on. Yes.
Okay. The reporting templates, and then we'll talking about in a case-based learning pattern, just to give a brief overview of how the MRI imaging is on the CA of the CA rectum. So, do we need an endorectal coil for the patient preparation recommendations? What we should follow for if you are referring a patient for a CA rectum MRI? So, do you need tell the patient to fast? So we can put enema. Do we need put enema? Do you need the serum creatinine levels? So we need to put a IV contrast. I would say none of these. So we do not need an endorectal coil. We are not probably using this like since ages. And we do not need an enema preparation. We do not need an IV contrast. We just maybe in some cases we can use Buscopan or any other spasmolytic, IM or oral tablets. But even then, it usually suffices without this spasmolytics also. So this is the basic MRI protocol, and we just need no IV contrast, just we need a high resolution T2 weighted images. And these T2 weighted images have to be orthogonal to the tumor. So basically it has axial oblique and coronal oblique to the tumor. Now this is very important. When the technician is not knowing where to take the scan, how to acquire the scan, this all will lead to a misreading of the scan. So we need to tell, and we need to have the proper clinical notes also as to where the colonoscopy detected the tumor, so as to give us a confidence level where to detect the tumor and how to acquire a proper imaging. So this is how, in this picture, this is the sagittal T2 weighted image, and we can see the white white hyperintense urine in the bladder. So this is a T2 weighted image, and we are acquiring a sagittal oblique. This is the tumor, and we are acquiring a orthogonal plane. So this is how we acquire the axial oblique planes. If we do not tell the technician where the tumor is, he will acquire a normal axial planes, axial scans, and this will not suffice to what we exactly need. So, and similarly, we need a coronal oblique perpendicular. Similarly, for the low tumors, the sphincter anatomy to delineate it exactly, we need a orthogonal planes. Another important, so basically, I'll be talking about the T2 weighted images and the diffusion images. These are the mainstay in MRI in delineating the rectal anatomy. And preferably a 3 Tesla is preferred, and we use a phased array coil. So this, I think ma'am has already told in detail, and this is the mainstay of the surgical treatment, TME, or the total mesorectal excision. We'll be talking about the anatomy of the mesorectal fascia soon. So basically, MRI informs the treatment decisions, and the type of surgery, if it's a low anterior, the distal margin of the treated tumor should be above 1 centimeter line above the anorectal junction. And here on MRI, we can define how is the anorectal junction, where's the distal margin of the treated tumor. So that is accordingly the treatment decisions are made. Whether the patient has to undergo an APR, extra elevated APR, pelvic exenteration, or he can underwent a local excision and selective pelvic lymph node dissection. So this is just a pictorial description of the various surgeries. And if the tumor is high above in the upper rectum, the patient can undergo low anterior resection. If it's already involving the anorectal junction and you cannot find a margin, it's less than 1 centimeter, and then it has to undergo the abdominal perineal excision. And then we have the newer intersphincteric surgeries where we can save the external sphincter. So this is usually the treatment plan we follow, and the localized or the T1 or T2 stages go for upfront surgery or the endoscopic resection, and the locally advanced, for example, in the T3C stage or the MRF positive or the nodes positive or the EMI positive, will undergo a neoadjuvant. Further, we'll do an MRI restaging. If it's a clinically complete response, then the patient usually goes to a surveillance via endoscopy, CEA levels, or MRI. If the surgery is planned after MRI staging, a surgical follow-up surgery can be done. Or if it's again if it needs another course of chemoradiation, then he will undergo a long course of chemoradiation. Yes. So we do have challenges in MRI reporting, and we need to know the posterior pelvic compartment anatomy and its variants. We just talked about the various fascias, how we see those on MRI, I'll be telling you. And some very early, very low rectal tumors, and the mucinous one are the notorious ones. But how to look and be sure of the pathology, the mucinous pathology in MRI, and the clinical tumor features which we need to tell about. So what do we, the rectum we know as the lowermost GI part, and about, we divide it into high, mid, low, and that's from the anal verge to the sigmoid takeoff or the rectosigmoid junction. The low part contains the anal canal as well, and we divide it as 0 to 5 centimeter. The mid is 5 to 10, and high is 10 to 15. There might be variable definitions according to surgeons and anatomists, but this is what we generally follow on MRI. The sigmoid takeoff How do we define that? When the vertical part of the rectum becomes horizontal. This is more obviously seen on the axial scans, but here also with the anterior peritoneal reflection where it attaches to the anterior rectal wall. And much above that will be the sigmoid canal. That's the peritonealized part. So, and the anal verge. So anal verge is the lowermost hypointense line, and that would be easily seen and easily seen on the sagittal oblique scans. The rectal wall anatomy is very beautifully seen on the high resolution T2 weighted images. So we have the hypo-intense mucosa, which is then surrounded by hyper-intense submucosa. Now, this submucosa would be generally depends upon the distension of the rectum, and it's not usually like very properly seen, but when seen, it's hyper intense submucosa fat. Then we have the muscularis propria, and this is where the MRI assumes importance, because the muscularis propria is a very hypo-intense line. It is the inner circular and outer longitudinal muscle layer, and usually the tumor is of intermediate intensity. And when it's a T3 stage, it has already reached the muscularis propria. So it invades the muscularis propria, and we can easily identify the most invading margin of the tumor, as well as the distance of the tumor from the MRF and the CRM status. So mesorectal fascia. So mesorectal fascia, as we just talked about in the surgical anatomy, it's the fascia covering the covering the rectum, mostly in the lower part. And in the upper and the mid rectum, further it becomes peritonealized anteriorly and laterally. But in the lower part, it's on the MRI and the T2 weighted scans, it's seen as a thin, hypo-intense, fine layer completely surrounding the rectum. So we have this CRM, and you need to define the CRM status on MRI. And how do we, what is the CRM? Is the distance of the tumor to the mesorectal fascia. It basically defines the resection plane for the surgeon. And it has to be defined in terms of everything, like the tumor distance from the MRF, it's the nodal distance from the MRF, and the deposits, if any present, the deposits, whether they're sitting on the mesorectal fascia or what is the distance away. So usually if it's the less than 1 mm, then it becomes a CRM positive, or CRM is involved. So MRI is highly accurate for CRM, 94 to 100% sensitive and 85 to 88% specific. So this is how the CRM involvement will look like. The distance of the tumor from the mesorectal fascia, or the nodal node, if it's sitting on the MRF or not, on the mesorectal fascia or not. Then a very important another key structure would be anterior peritoneal reflection. Now this will be really helpful to define the treatment strategy. And how is it identified? So basically, it's a very thin hypointense line presenting as a seagull sign on the axial scans. And it might present like in the sagittal, you can see a very thin line, thin hypointense line. So this is the anterior peritoneal reflection coming from the anterior rectal wall up to the superior part of the bladder in men. And if it's we do have if it's a women, then it's extending up to the torus uterinus. So basically, identifying this anterior peritoneal reflection is easier in sagittal planes. If you just scroll the scan, you find a thin hypointense line extending from the anterior rectal wall. So this is how we just talked about. The upper high rectum is peritonealized on anteriorly and laterally. Peritoneal reflection, the mid rectum is anteriorly. And in the lower rectum, it's completely extraperitoneal and surrounded by the mesorectal fascia. So mesorectal fascia, then anteriorly, it merges with the retroprostatic or the denovelar fascia, and posteriorly, it's the presacral fascia. Now, just to talk about the relevant anatomy in this lower rectal tumors, or the anal canal, involving the sphincter anatomy. So the internal sphincter is is a muscular layer, and within see it as a hypointense layer. This is the axial scans. These are the coronal scans. The intersphincteric plane, on the other hand, is a fat line plane, and then it is again considered as a plane for resection. This is a fat containing hyperintense plane. Then we have the hypointense external sphincter. External sphincter, the puborectalis, the upper margin of the puborectalis, the levator ani, the horizontally shaped, and then this forms the external sphincter. So external sphincter is again can be divided into deep, superficial, and subcutaneous. And the subcutaneous is the lowermost limit of the external sphincter, the hypointense line, and usually merges with the skin. So in the colonoscopy, there might be few discrepancies in the level of the tumor from the anal verge by the gastroenterologist and by the MRI specialist, because we take the tumor distance from the subcutaneous part of the external sphincter. So this is all we know. Levator ani muscles form the pelvic floor. These are best seen on the coronal T2 planes as horizontal. The puborectalis muscle cinches in the funnel and contributes the fiber to the external anal sphincter. And for tumors below the puborectalis, the CRM is defined as the intersphincteric plane or the levator muscle. So if the tumor has invaded the intersphincteric plane or the levator muscles, then it becomes a CRM involved tumor. So this is how we present the report in a template. This is by the Society of Abdominal Radiology. And the primary tumor, we give the distance to the anal verge, distance to the top of the sphincter complex or the anorectal junction, relationship to anterior peritoneal reflection, whether the tumor is above the anterior peritoneal reflection, whether it is straddling or just at the level of the anterior peritoneal reflection, or whether it's below. The total length of the tumor location, whether it's in the upper, mid, or the lower rectum involvement, morphology of the tumor. This is very important to know about where the tumor is in a circumferential manner. So whether it's completely circumferential, whether it's semi-annular, partly annular, and how does the tumor is? Is it a polypoid lesion? Is it a mucinous one? No mucin, some mucin, or mostly mucin. So mucin component is really hyperintense, avidly hyperintense on T2. Then we can give the T staging. So these are the steps. First, we need to find the tumor. So the tumor is, as we talked about, it's the intermediate intensity. It has elevated edges. So this is how you identify the tumor. And then we have to describe the tumor, the distance from the anal verge. Now, distance from the anal verge has to be taken along the planes just as the colonoscope goes. So we take a slightly diagonal plane according the luminal distance from the anal verge. Similarly, the location, the relationship to the anterior peritoneal reflection, the T3 stage finally. If it is a T1, T2, it is limited to the submucosa. If it's invading the muscularis propria, it becomes a T3 stage. Then T3, again, we need to identify the distance, the maximum distance beyond the rectal wall. And then we have to specify whether it's a MRF positive or MRF negative. And if it is anteriorly going beyond the peritoneal reflection involving the other organs, then it becomes a T4A stage. So T1, T2 are confined to rectal wall. T3 is beyond the wall. A, B, C, D, less than 1, 1 to 5, 5 to 15, and greater than 15. T4A invades the peritoneum. T4B is invading other structures which may involve pelvic organs like ureter, skeletal muscles like levator, vessels, nerves outside the mesorectum, extra mesorectal compartments, bone, distal bowel. So all this can be easily identified on MRI scans. Then we have talked about MRF is involved if the tumor is less than 1 mm from MRF. Then the anal sphincter complex invasion has to be talked about, whether it's involving the internal sphincter, intersphincter plane, or the external sphincter. So this was the 8th edition of the TNM staging, and it has added one more M1C stage, which says peritoneal mets with or without metastasis of other organs. So step 4 is the very important thing is the EMVI, or the extramural vascular invasion. What does the term stands for? So basically it's a tumor, it is extending via the lymphovascular spaces. The tumor excrescences, the tumor intensity can be seen within the vessels. So it has a poor prognosis, and this can also be easily seen and identified on MRI. Then we have the T stages is finished, the EMVI is finished. Now we come to the nodal staging. The nodal staging here, in cases of CA rectum, it's not only based upon size, it is based upon morphology of the lymph node also. So even if it's a less than 5 mm node, you can't say that it's not a positive node. If it is morphology is round, the signal intensity is heterogeneous, and it has irregular borders, then all the 3 characteristics of the morphology will add up, and then it becomes a suspicious lymph node. If it falls in the bracket of 5 to 9 mm, only 2 suspicious morphological characters are enough to say it is a suspicious node. And if it's greater than 9 mm, then any one morphological character, or even none of the above, will tell that if it is a suspicious node and has to be resected. So nodal status, N0 stands for no nodes, N1 if you can see 1 to 3 suspicious nodes, N2 is if it's more than 4 suspicious nodes. Then you have to involve the extramesorectal nodes also in your reports, and to talk about the lateral pelvic lymph nodes, the obturator, the internal iliac, the inguinal, and the highest involved nodes, which will be the pre-aortic, para-aortic, if any present. Although unlikely, but if any present. Then we have to talk about the tumor deposits. Tumor deposits are again tumor signal intensity lesions seen within the mesorectum mostly. So this is how we have the MRI reporting template. So I would just give a few of the cases. This was a phase 1 70-year-old female with PR bleeding, and a colonoscopy they found a polypoidal mass at about 5 centimeters from anal verge. So this is how the mass was. This is a big polypoidal mass with a puckering at the posterior wall, and on the axial scans we can see the mass quite clearly. It is reaching up to the muscularis propria, and this is how the coronal oblique looks. So the tumor, the location from the anal verge, it was 5 centimeters. It is involving the mid and the upper rectum. Distance from the anorectal junction. So anorectal junction here we can see. Anorectal junction is usually defined by 2 anatomical landmarks. So one is the internal sphincter muscles usually go thick around here, and the other good landmark I would say it's the upper limit of the puborectalis muscle. So puborectalis basically forms a sling, and it is arising from the inferior pubic ramus to the anococcygeal raphe. And this puborectalis sling can be easily identified when we scroll the sagittal images. So a sling-like thing goes around this, and the upper limit of this would identify us the anorectal junction. So here the anorectal junction is completely uninvolved, and the tumor is below anterior peritoneal reflection. The craniocaudal length is about this much. Circumferential location. So circumferential location, it is mostly from 2 to 5 o'clock position. Morphology is polypoid, no mucinous component, as I cannot see any T2 hyperintense components. And the T staging is PT2 or early T3. So here the muscularis propria is almost invaded, so it could be an early T3 stage. Another case, 37-year-old male with altered bowel habits with PR bleed. And now here the tumor margins can be easily seen invading the muscularis propria and coming out from the rectal wall. So here it becomes a T3 stage, T3C stage. We have to identify the tumor, how much is the length of the tumor from the rectal wall. So location from the anal verge is about 3.8 centimeters. It's below anterior peritoneal reflection. The cranial caudal lens, circumferential location, morphology, a mucinous component is present or not, a T staging, and minimum distance from MRF. Now, this is very important to identify the MRF for the thin hypointense line and to give a minimum distance from the MRF. So it becomes a CRM negative because the minimum distance is more than 2 mm. So 1 to 2 mm distance, if it's there, it becomes a threatened MRF, and less than 1 mm, it becomes involved MRF. Nodal staging, there were one suspicious lymph node. So post CT scan of a 76-year-old female, but here I have included this case just to show the mucinous component of the mass and to show the sphincter invasion. So from the anal verge, it's only 4 millimeter. Craniocaudal length is 6.8. The circumferential location morphology is polypoid. The mucinous component is yes. And the anal canal, everything, the external, internal, and the intersphincteric space, everything is involved. This is external sphincter. This is involved. No intersphincteric plane can be seen on the right lateral wall, and the internal sphincter is involved. So this becomes a PT4B with possible invasion of vagina and possible invasion of the pelvic floor. This is below anterior peritoneal deflection, and there are at least 6 suspicious lymph nodes was in their scan. This was also another case with post-hysterectomy status, and this is a large tumor. Now this case has been included to show the EMVI. So this is how the EMVI looks like, the linear tubular excrescences of the tumor. So this was EMVI positive scan. I will just talk a little about the response assessment, which is gaining a very important role in MRI. So MRI features of response, how do they look like? The T2 signal changes from, and it requires a darker signal or a fibrosis. So this was the tumor initially, and post NACT it assumes a darker or the fibrotic signal has taken over. Similarly, the diffusion intensity also decreases, and so we take a diffusion scan as well for the response assessment. So this was a Mercury trial initially and indicated a good MRI tumor regression grade. The tumor regression grade 1 or 2 with the predominance of fibrosis, 3 with substantial tumor still, 4 with the predominance of tumor, and 5 was like no change was found in the tumor. So following therapy, we have another report template which states the YT stage and the YN stage, how much the tumor has regressed, and what are the T2 and diffusion signal. So based on the T2 and diffusion signal, we judge. This was a newer study which says a split scar sign, which is indicator of a sustained complete response after neoadjuvant therapy. And it's very frequently seen, and if read carefully, it is a complete clinical response. So nowadays, a watch and wait trial is also been on the, and it depends quite a lot on MRI. So post-treatment response, this was a case with a large tumor sitting on the right lateral wall. This is how the post-treatment, the tumor has shrunken, but still the involvement, this was supposed to be, this was likelihood of EMVI or large tumor deposits, but these were also shrinken. So this is the diffusion scan. This hyper intensity has shrunken to a minimal of this. This is how the tumor was initially, now shrunken to found a dark signal corresponding to fibrosis. This could be considered as a split scar sign as well. These are the contrast enhanced scans. So contrast enhanced scans in post staging of, in post neoadjuvant staging of rectal cancer has assumed importance nowadays and can be carried out. And the ESGAR guidelines on the rectal cancers, this about the nodes, the nodal size, the cancer staging advises to consider nodes less than 5 mm after neoadjuvant therapy to be considered benign. However, in nodes greater than 5 mm, false positive nodes are found. If complete luminal response, then when the nodes have responded, sometimes watchful waiting is considered with close follow-up of the nodes. So this was how the various level scores, if on the T2 diffusion and post-contrast, these features will suggest a complete response with the linear 1 to 2 mm hypointense scar with no residual hyperintensity on diffusion, with normalized rectal wall or progressive enhancement of the layered fibrotic wall, no involved nodes will be complete response. Then we have the 2 categories as near complete response, then partial response, and then no response at all. So this was how the scoring was done. then pathological grading and the MR tumor response grading were compared. This is the residual tumor mass, and how we gave it as on the T2 signal, it was given as scale 1, that is near complete response. On a diffusion scale was also given as near complete response. Contrast enhancement is found to be delayed enhancement, which again means that a fibrosis has occurred. This was given as near complete response. All the other details were given. Only the external sphincter was spared. So internal sphincter, intersphincteric fat was involved. So in summary, MRI is very important, and it forms the mainstay of the imaging of CA rectum, and good quality MRI images are very important with small FOV, T2 oblique orthogonal images, and the location is everything. The low tumors, as we all know, are the bad ones. And the CRM MRF involvement is essential, and we need a keen trained eye so as not to miss even a small deposit or lymph node to reduce the chances of local recurrence. And the structured reporting is very beautifully shown and is being carried out at our institute so that we can not miss any other feature. Thank you.
Thank you, Sangeeta. Before I hand over to Deeksha and Ram, one question which we examiners very often ask the students in the exam when they get a case of CA rectum, that what is the preferred imaging modality? So some students say both CT and MRI, some say MRI pelvis, CT chest and abdomen, some say MRI abdomen pelvis and CT chest. So as a radiologist, what is the best imaging which would evaluate the local disease, the liver metastasis, and the chest also?
So I would suggest CT, thorax, abdomen, pelvis, so as not to miss any liver or chest metastasis, and MRI pelvis for the local evaluation of the CA rectum.
Okay, over to you, Ram and Deeksha, please.
Thanks, Sanyukta. I would like to thank from all the surgeon sides. Actually, it was very informative talks for all of us.
Thank you, sir.
I would just like to know, since my residency time, we are hearing that MRI is the best modality for this rectal cancer. But still, in our practice, we are not getting this kind of images in most of the time. So MRI protocols for rectal cancer are still not well established at most of the center. What is the reason for that?
I think, sir, we are not. We need to know as a multidisciplinary team the prerequisites, the actual machinery, and as a radiologist, I would suggest working at like a private setup has like. I usually encounter these type of images only, and these are supervised by us radiologists only. So what is happening in India mostly at the local levels, we do not, the radiologist is not sitting on the screen on the screen to manage the protocol, the MRI happening. So that's one lag, I think. And of course, the imaging quality depends on the machine. There's a lot difference between the 1.5 Tesla images and the 3 Tesla images. And the FOV, the motility of the gut has to be taken care of. The susceptibility artifacts arise from the air in the rectum. That we decide that if it's large, we give a small amount of enema as well sometimes. But it has a doctor sitting over there. Mostly.
Other thing I would like to know, with newer generation of CT, with more than 1,000 slice CT, are they going to this kind of CT? Are they going to compete MRI for rectal cancer?
No, sir, never. The beautiful mucosal anatomy which MRI gives, it can never be given on CT, however better slices or ever thinner slices. But what is important in cases of IBD and ulcerative colitis, the skip lesions, these can only be picked up on CT. Like if we are suspecting a young patient, and we have to rule out the skip lesions, when you have to rule out the other polyp synchronous lesions, then I would suggest undergoing for the local staging MRI rectum, but for the extensive staging it has to be CT enterography. Then also the machine, the reading, everything is very essential. Plays a role.
Great talk, Dr. Sanyukta. I have one question.
Thank you, ma'am.
One question for you. For our younger colleagues, and I think just as a reminder to all practicing surgeons, what history and examination findings should be written in our OPD paper so that you can perform a good MRI for us?
Yes, ma'am. That's a very important question. So I would always want my colleagues to hand me over the colonoscopic, first of all, the DRE findings and the colonoscopic findings. These are very helpful to us for the planning of the tumor. If the sections do not cover the tumor and we are just assuming the tumor distance from the anal verge or the upper limit or the lower limit, doesn't make, then it's futile. The whole exercise is futile. But if we get a good DR, then we need, and the post neoadjuvant, we need the CEA levels also as well. So that gives us a confidence level that the CEA levels are decreasing, that patient is in remission. And yes, so I would need endoscopy, CEA levels, and any other clinical examination. If any fistulectomy has been performed before, that also. If any perineal surgery has been performed before, I would need that details as well.
Thank you. Thank you for that. I just want to emphasize this for our younger colleagues and for the residents who are listening to us, that a well-performed rectal examination, per rectal examination has no shortcuts. Only if the findings, only if it's been performed well and it's been documented well, will the radiologist and the technician perform a good MRI, because the axial cuts need to be perpendicular to the longitudinal axis of the tumor. If they are not, then it stages the tumor incorrectly and actually has an impact on all the decisions that are made from that point onwards.
Right, ma'am.
I have a question, Sayukta. This question came up during a case discussion just this Saturday, CA rectum. So in CA rectum, we would always like to evaluate the rest of the colon, but suppose the growth is causing luminal obstruction and then scope doesn't go beyond the growth, then what method would you prefer or advise to evaluate the rest of the colon? Because for a virtual colonoscopy also, you would need the bowel to be prepared.
Yes, sir. So CT enterography, we usually use the negative oral contrast. So negative oral contrast is water containing. So we can give, but so even if the the scope is not passing by, we get to know if the walls are involved or is an extra luminal spread of the tumor. And so then I would advise a CT enterography, CT enterography, and it will help us to find the level of the obstruction.
Not for the primary tumor. Primary tumor you would evaluate by MRI.
By
We are
MRI.
now wanting to look at the rest of the colon, whether any synchronous lesions are present. So for doing a virtual colonoscopy or a CT colonoscopy, colography, do you need the bowel to be prepared, or can we go ahead and get it done even with an unprepared bowel?
No, sir. We need to bowel to be prepared for a CCT colonoscope,
So
CCT
that was the
enterography.
question, that if there is obstruction and we cannot cleanse the bowel proximal to the tumor, then can radiology help us in any way
Yes, sir.
to
So we can, yes, sir. So we can help we can ask the patient to fast for 4 to 6 hours, and that will help us enough. And even if the oral contrast is not 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 palate not no, avoided. He's not able to take the oral contrast, then also the fasting will suffice, and we can see the easily the virtual colonoscopy and the CT enterography will delineate the level.
So what is the smallest size of a lesion, say a polyp, which you can see on unprepared bowel on CT colonoscopy?
The smallest size of the polyp. So that's really difficult because the endoscopy has the obviously the luminal sensitivity more, but as such I couldn't remember any exact size of the literature, but
Deeksha or Ram, would you like to say something on this? That scope is not passing through. You try to prepare the bowel, but the bowel doesn't get prepared. So how do you evaluate the remaining colon?
So, I mean, I think radiology will, there is no other option left except for a good CT scan. But at the same time, we must understand that it's not a foolproof endeavor. We might end up missing a few small polyps, but unlikely that a large growth or a malignant growth will be missed. But yes, I think the fact that the entire colon has not been evaluated completely needs to be documented in the patient's case file and history and discharge summary, and even the operative notes to be very extreme, because the patient should come back for a colonoscopy after the surgery at least. We also
That's
must
very
we also must realize that in an obstructing tumor, we are going to end up giving the patient some kind of chemotherapy, and the polyps will actually end up responding to that.
Yeah, I think Dr. Chetan wants to make a comment on that. Chetan, please unmute yourself and then we can proceed
Yes,
with his
sir.
presentation.
I would like to answer this question in a very different way. First is I would say that this patient, if I can get a prior information about the proximal colon, it's well and good. But I'm not going to make a fuss about it because the surgery I'm going to plan is a decompressive stoma, or at the most I can pass a endoscopic stent. Following decompression, I can then evaluate the rest of the bowel because this patient is going to be subjected to neoadjuvant chemoradiotherapy prior to a definitive surgery. So that is the way I would answer.
So that
Okay.
may be true for a rectal tumor, not necessarily for the colonic.
Yeah, for rectal tumor. I'm
Yeah.
talking of rectal
Yes,
tumor.
yes,
Yeah.
yes.
Now,
Sanyukta?
Yes, ma'am.
Yes, sir.
no, go ahead, please.
So I wanted to ask about the endoanal and endorectal coil MRI. We usually ask it for the assessment of the sphincters and fistula, sphincter injuries and level of injuries and extent and the fistulas. Any indication of that in the malignancy, CA rectum, especially endorectal coil, we never ask, and sometimes it is not available and all those things.
So, ma'am, in the recent literature about like 8 to 10 years, I would say, they haven't talked about endorectal coil anywhere. And they only talk about the high resolution small FOV, T2 oblique and axial images are sufficient even for the fistula reporting and even for the malignancy. Or MRI pelvis and perineum has come upon the phased, we use a phased array coil. That's a body coil only, but we place it on the lower pelvis, and that's enough for giving us a high quality images.
For the sphincter assessment, benign injuries of the sphincter also without endoanal coil, you will be able to report.
Yes, ma'am. In my experience, we are doing only the without endorectal coil. We do not have it.
Sayukta, one last question to complete the discussion for the benefit of students. Where in your investigation algorithm will you place the role of PET-CT for CA rectum?
Yes, sir. So, as a radiologist, PET-CT comes in the similar, if the locally advanced tumors have to be staged on this, stage on the MRI. But if the patient is not undergoing a CCT chest and a CCT TAP, thorax, abdomen, pelvis, I would suggest replacing it with a PET-CT would also suffice. Like PET-CT, it has to be done for obviously the whole staging of the tumor, the complete, but cannot replace the MRI rectum for the local staging.
It cannot replace for sure.
Yes.
Would you always advise it prior to giving neoadjuvant chemoradiotherapy?
Prior to, yes, sir. That gives a complete overall view. Yeah. Yes, sir.
Thank you. Thank you very much.
Let's move on. We are eating into Dr. Chetan's time. Let's move on.
Thank you, sir. Thank you.
Thank you very much.
Yeah, so maybe I'll introduce Dr. Chetan, is one of the senior most GI surgeons. He's the chief of GI surgery at the prestigious KEM hospital. And he's going to talk on the relationship between IBD and cancer. Dr. Chetan, please.
Kindly, sir, permit me to share the screen.
You are already a co-host. Please
Okay,
go ahead.
okay.
No? Yes, yes. Yes, we can see. Please unmute yourself, Dr. Chetan. You are muted. Yes.
Okay, am I visible?
Yes, yes, please.
Okay. So good evening, everybody. Respected Kapoor sir, distinguished moderators, seniors, colleagues, and friends. The topic of my today's discussion is malignancy associated with IBD and FAP. So, as shown in this diagram, IBD can affect malignancies at all levels, beginning from skin, lung, it can cause cholangiocarcinoma, it can affect the small intestine, the colon and rectum, the anal canal, and also hematological malignancies. Besides this, the therapy related to IBD as well can lead to malignancy. So let us look into detail of how this occurs. So we all know that colorectal carcinoma is one of the most common malignancies associated with inflammatory bowel disease. Ulcerative colitis is a well-established risk factor for CRC. Its incidence is 4 to 10 times more as compared to the sporadic CRC which can occur. And the risk increases after 8 to 10 years of diagnosis or following diagnosis of high-grade dysplasia. So the risk at the end of 10 years is around 1%. It is 2% at the end of 20 years. And after 20 years, it is around 5%. In comparison, the association of colorectal carcinoma with Crohn's disease is not so well established and is a controversy. The common risk factors which have been implicated are the primary sclerosing cholangitis, where it is said that it increases the risk 3 times the normal, severe inflammatory activity, presence of post-inflammatory polyps, diagnosis made at a younger age, longer duration of IBD, extensive IBD with highest risk being in pancolitis, colonic strictures, left-sided colitis have intermediate risk, family history of first-degree relatives with colorectal carcinoma are more predisposed, and so are male gender. Now, as far as the pathogenesis of malignancy in IBD is concerned, it usually follows an inflammation dysplasia carcinoma sequence as compared to the adenoma carcinoma sequence which we see in sporadic colorectal carcinoma. Besides this, the molecular alteration in IBD also occurs in different order and frequency. In IBD, we see that P53 mutation occurs earlier and mutation in APC gatekeeper gene occurs later, just prior to carcinoma, in comparison to the other way around in sporadic malignancy. As far as the bacterial involvement leading to malignancy is concerned, there are three theories which have been put forward. The first is alpha bug hypothesis, which affirms that a single bacterium can lead to development of carcinogenesis. Second is the driver passenger hypothesis, where it states that after the first bacterium has been implicated and caused carcinogenesis, other opportunistic bacteria also add and contribute to further progress and development of malignancy. Whereas the common ground hypothesis states that there occurs increased permeability of the bowel following bacterial invasion of submucosal tissue, which leads to chronic inflammation and development of carcinoma. Now, how do you actually pick up this malignancy? So for this, patients should be under surveillance, and the recommendations as per the various guidelines are that patients with lower risk, that is colitis less than 50%, or patients with extensive colitis but minimal endoscopic or histological inflammation, they should be surveilled at every 5 years. Patients with intermediate risk, that is extensive colitis with mild to moderate endoscopic and or histological inflammation, and with patients with first degree of family member having malignancy but more than 50 years of age, they should be surveilled every 2 to 3 years. Whereas patients with peripheral sclerosing cholangitis, extensive colitis with severe endoscopic and histological inflammation, colorectal malignancy in first degree with less than 50 years, patients with strictures in last 5 years, and dysplasia in last 5 years should be surveilled annually. Now, what do you besides this, it is also said that an annual pouch surveillance should be done in patients who has undergone a ileopouch anal anastomosis, in whom the preoperative diagnosis of dysplasia or malignancy of the colon or rectum was there. Now, what do you actually see on this colonoscopy? So you will stratify the lesion depending upon the site, size, shape, surface, and surroundings. Now, it is important to do this because less than 2 centimeters, you can endoscopically resect it or do EMR or ESD for larger lesion. Polypoidal lesion can again be treated differently if it is less than 2 centimeters or more than 2 centimeters. As far as the shape is concerned, as shown in the diagram, you get these different shapes, and each shape has a therapeutic implication of what you should be doing. Besides this, you also would want to know the degree or severity of dysplasia, whether the dysplasia is high-grade dysplasia, low-grade dysplasia, and unclassified atypical. Now, what do you do once you know that there is a dysplasia? So if there is a polypoid lesion or a non-polypoid lesion, which is less than 2 centimeters, without stigmata of invasive malignancy or fibrosis or distinctive border, then you could do an endoscopic block resection, that is either endoscopic mucosal resection, submucosal dissection, or a hybrid technique, and it should be undertaken by expert endoscopists. These patients are then post-procedurally followed up with close surveillance with either a chromoendoscopy or with targeted biopsy. Patients with high-grade dysplasia for first year should be surveilled every 3 months and subsequently annually. Patients with non-polypoid low-grade dysplasia should be surveilled every 6 months and then annually. Non-polypoidal lesion more than 2 centimeters without stigmata of invasive malignancy or fibrosis and distinctive border, again go an endoscopic resection, or you are justified in doing surgery as well if you are not comfortable doing it endoscopically. Again, like above, you have to surveil this patient periodically, every 3 to 6 months for first year and then annually with a colonoscopy. For an unresectable large lesion or with invasive carcinoma or an invasive dysplasia or random biopsy, again, you do surgery. You need to confirm before undertaking this the report by a second pathologist. Do a repeat surveillance colonoscopy should be done in invasible dysplasia and follow it up with annual surveillance. For indefinite dysplasia, again, you repeat the the biopsy and confirm it by a second pathologist and keep them under surveillance with annual surveillance colonoscopy. With multifocal dysplasia, either low-grade dysplasia or high-grade dysplasia, surgery is the treatment of choice. And for sporadic adenoma, you could do an endoscopic en bloc resection. Now, here it is again, I want to emphasize that patients with unresectable non-polypoid dysplasia, they were higher risk of going into high-grade dysplasia or malignancy within 5 years, and hence, regardless of the grade of dysplasia, they should be subjected to colectomy, either a total colectomy, or in case of a low-grade dysplasia, you could do a partial colonic resection and keep them under surveillance. Now, what about primary prevention? Can you prevent malignancy occurring in patients of inflammatory bowel disease? Yes. So this primary prevention is independent of screening and surveillance strategy, which we discussed. The strategy is to control inflammation. And in this context, 5-amino-salicylic acid plays a great role in preventing colorectal malignancies occurring in patients with inflammatory bowel disease. What it does is it downregulates the cyclooxygenase 2. It inhibits the activation of transcription of nuclear factor Kb and phospholipase D. And it is believed that in doses more than 1.2 gram per day, it offers a significant protective effect in patients with ulcerative colitis. Now we come to small bowel malignancies. So small bowel malignancies is believed to cause 8-fold and 2-fold increased risk of small bowel adenocarcinoma in Crohn's disease and ulcerative colitis. So it is very clear that as far as small bowel is concerned, it is Crohn's disease which is the villain rather than ulcerative colitis. But however, the risk of neuroendocrine tumor is equal in both patients of ulcerative colitis and Crohn's disease. The risk factors in ulcerative colitis are extensive involvement and presence of peripheral sclerosing cholangitis, whereas in patients with Crohn's disease, it is the area which gets affected and the ileocecal region or the proximal colon, which is usually involved. So the risk factors for development of small bowel adenocarcinoma are use of tobacco, male sex, early onset of Crohn's disease in childhood, long-standing small bowel inflammation, presence of penetrating or stricturing Crohn's disease, and patients with history of prior small bowel resection. Now, as far as the small bowel cancer in Crohn's disease is concerned, there is increased risk for developing both adenocarcinoma and NET, as we have discussed. It commonly affects the areas where there is inflammation, the distal jejunum and proximal ileum, and you should suspect the presence of malignancy in patients with refractory, long-standing stricturing disease or patients who present with relevant symptoms. And as far as surveillance is concerned, as of now, routine surveillance either with imaging or endoscopy is not recommended for small bowel cancers at present. Now coming to intestinal lymphoma. So intestinal lymphoma, it occurs around 2 to 3 times more in individuals with inflammatory bowel disease. It is seen more often in males, and it is predominantly B-cell non-Hodgkin lymphoma or lymphoma associated with Epstein-Barr virus, which occurs in them. It occurs in patients where there is ongoing intestinal inflammation for more than 8 years, and more so in patients who have been receiving treatment in form of thiopurines, a common immunosuppressant agent which is used. Now coming to anal carcinoma. Though the development of anal carcinoma in patients with Crohn's disease is not very high, but it is definitely higher than the general population. So incidence of anal squamous carcinoma is around 2.6 per 10,000 per patient year in patients with IBD with presence of anal or perianal lesions. So the risk factors are presence of humanopapillomavirus and patients with long-standing perianal and fistulizing diseases. Now coming to cholangiocarcinoma. Cholangiocarcinoma occurs 4 times more likely in patients with IBD. The lifetime risk in these patients of inflammatory bowel disease to develop cholangiocarcinoma is as high as 5 to 10%. So it occurs, the incidence is around 7 to 7.6 per 100,000 patient years among patients with IBD. And this risk increases by more than 150 times if these patients have concomitant PSC along with IBD. Hence, surveillance for cholangiocarcinoma is recommended in all patients with IBD and PSC, regardless at which stage they present. And this is more true when in first year after diagnosis. Hence, they should be surveilled. So how do you surveil it? You do an appropriate imaging, either by MRI and MRCP, along with LFT every 6 to 12 months. Now coming to extraintestinal malignancy. It has been seen that inflammatory bowel disease is associated with non-melanoma skin cancers, hematological malignancies, lung cancers, melanoma, multiple myeloma, and non-Hodgkin's lymphoma. Now, whether these hematological malignancies, they occur because of inflammatory bowel disease or because of the treatment being given to them, and it is the drugs which leads to development of hematological malignancies, is not very clear. And as of now, there is no insufficient evidence to implicate either of them. So now what are the common drugs used which can give rise to malignancies in patients with receiving therapy for IBD? So thiopurine can give rise to lymphoproliferative and myeloproliferative disorder, non-melanomatous skin cancers and cervical cancers. TNF antagonists can give rise to lymphoma and melanoma. When TNF antagonist is used in combination with thiopurine, it can give rise to lymphoma. Vedolizumab and ustekinumab, fortunately, no malignancies have been detected, and therefore we can make use of this when you detect malignancies in patient with IBD. JAK2 inhibitors, they can cause all malignancies but for non-melanomatous skin cancers. And methotrexate is known to give non-melanomatous skin cancers. So let us discuss in brief about important drugs. So thiopurine, there is increased risk for lymphoproliferative and myeloproliferative disorders. The risk is more in elderly patients. Hence, it is important that you screen them for Epstein-Barr virus, especially in young adults, before starting therapy. And in patients with negative EBV IgG, you should think of other medications than thiopurines. As far as skin cancer and thiopurine is concerned, there is increased risk for non-melanoma skin cancer. And therefore, these patients, before starting the treatment, should undergo a skin cancer screening and use sun protective measures. As far as cervical abnormalities in females is concerned, it is well established fact that they have increased risk of cervical high-grade dysplasias and malignancies. Therefore, women suffering from IBD and who are going to be started on thiopurine, they should undergo a screening program before starting of the therapy. Now we come to a situation where you have a patient of IBD and you on surveillance detect malignancy. So how will you manage? So I'm going to take you through this algorithm. So you have a patient with IBD and you detect a cancer. So there is a presence of, if there is a presence of active cancer, important is that you avoid immunosuppressors and anti-TNF. Then you find out whether you start the cancer therapy will get precedence over the management of IBD. And you see whether this cancer therapy also helps in managing IBD. If the answer is yes, then you continue with the treatment. But if it is not helping IBD, then you can start on steroids. And as I said, that vedolizumab or anti-TNF can be started. However, it's important to note that you should avoid immunosuppressants. Now, if you are not going to be starting an active cancer treatment, that is chemotherapy, and if the IBD is active, then you start on steroids or vedolizumab or anti-TNF. If it is not, you can start 5-ASA, but again, it's important that you avoid immunosuppressants. Now, we come to another situation where you have a patient who presents with IBD and gives history of malignancy in past, colorectal malignancy in past. So how do you manage it? So you find out first whether the malignancy remission is more than 2 years. And if it is yes, And if the patient has active IBD, then if patient has active IBD, depending upon the disease activity, if it is moderate, then you use steroids. If it is not effective, then you can use vedolizumab or anti-TNF or ersitinib. However, it is important that you avoid thiopurines and immunosuppressants. If the disease activity is mild, then you can start the patients on steroids or mesalazine. If the malignancy is, if the IBD is active, then you should avoid thiopurines and use mesalazine, steroids, and consult an oncologist for further treatment. However, if the IBD is not active, then you can give mesalazine. If the IBD is not active, then you keep the patient under surveillance. And if there is early detection of flare, you start on steroids. If there is no efficacy with it, then again, as we said, anti-TNF monotherapy or vedolizumab or ustekinumab can be started. So this is as far as the management of patients of IBD with prior history of colorectal malignancy. Now, in the end, I would like to say that as far as malignancy-associated IBD is concerned, the current scenario spells good news for us because the incidence for malignancy in IBD is declining over the years. And this can be attributed to improved controlled inflammation, maintenance therapy utilization, and a good surveillance program, which leads to early surgery in cases of medical resistant diseases. Now I come to the second half of lecture is that malignancy associated with familial adenomatous polyposis. So we all know that FAP is an autosomal dominant polyposis syndrome with varying degrees of penetrance. The primary genetic defect is a germline mutation in adenomatous polyposis coli gene. It has diverse phenotypic expressions like Gardner and Turcot syndrome, and the patient has 100% lifetime risk of developing colorectal carcinoma, especially by the age of 30 to 40 years. And hence, prophylactic colectomy is recommended in all these patients to reduce the risk of developing carcinoma by late 20s or early 30s. Besides this, it's very important to note they also have increased risk of gastric and duodenal adenocarcinoma, hepatoblastoma, and desmoid tumors. So as far as colonic manifestations of malignancy in these patients is concerned, they will present with diarrhea, abdominal discomfort, bleeding PR, and you would naturally do a colonoscopy, and you will be finding numerous colonoscopy, more than thousands, what they describe as a carpet of polyps. It's important to remember that you have an entity called as attenuated FAP, where there are reduced number of polyps, less than 100, around 30 polyps. This usually occurs at the later age, around 50 years, and it predominantly affects the right colon. So as far as the definitive management of FAP is concerned, the only definitive treatment is surgery, which includes total proctocolectomy with ileal pouch anal anastomosis. Having said that, there is a role for total colectomy with ileorectal anastomosis in certain select subgroup of patients. So who are this? Female patients who have yet to complete their reproductive life, patients who are young, who are to get married. So you ask them to complete this. And most important rider for doing ileorectal anastomosis is that they have to be motivated enough to be under constant surveillance, because in the remnant rectum, the distal rectum, there are high chances of malignancy which can occur, and you may have to do a completion total proctocolectomy in these patients at a later date. Now we come to extracolonic manifestations, and the most commonest extracolonic manifestation is congenital hypertrophy of retinal epithelium. It is asymptomatic and it is seen as a flat, localized, pigmented retinal lesions. Then you have patients who present with Gardner syndromes like osteoma of the mandible or skull, dental abnormalities such as impacted teeth, supernumerary teeth, odontomas, and cysts, which are usually identified on X-rays. You have desmoid tumors, and this can occur in as high as 10 to 15% patients of FAP. These are solid connective tissue tumors which are benign, but they have capacity of significant growth and local invasion. There is increased incidence in abdominal cavity, and patients who have family history of desmoid tumors, the risk increases by 25%. Females are more likely to develop this, and surgical trauma is usually associated with increased incidence. So they are large, firm, painless mass. They are oval or round with irregular margins. And as per NCCN guidelines, these group of patients require annual clinical examinations in form of abdominal palpations and imaging, especially in patients who have history of FAP and desmoid tumors. MRI is supposed to be best imaging modality because it can help you to assess the relationship with surrounding structures and also determine local invasion. You can treat them medically with anti-estrogens, prostaglandin inhibitors, tyrosine kinase inhibitors. Local therapies like cryotherapy and radiation have also been advocated. However, the definitive treatment remains surgical excision with negative margins. Now coming to gastric polyps, 90% of patients with FAP, they have gastric polyps. Majority are fundy gland polyps. They do not develop into cancer. However, non-fundy gland polyps, they progress into malignancy and they can be managed endoscopically. High-grade dysplasia in any of the gastric polyp warrants endoscopic or surgical resection depending upon its size and site. As per the NCCN guidelines, in these group of patients, upper GI endoscopy should be done regularly beginning from 20 to 25 years of age. If feasible, they can be treated endoscopically. However, patients with high-grade dysplasia and malignant degeneration, they warrant surgical resection. Now, periampullary and duodenal carcinoma, they are also very common. It arises amidst the duodenal polyps, and it is one of the leading causes of death in FAP after colonic cancer. The lifetime risk of these patients developing duodenal carcinoma is approximately 5%, which occurs by the age of 60. Their median age of presentation is around 50 to 55. It primarily affects the second and third part of duodenum, and hence these patients' surveillance should start at the age of 20 to 25 years, and endoscopy should be repeated every 2 to 3 years. Polyps with dysplasia should undergo an endoscopic resection. However, endoscopically unresectable polyp or polyp showing features of invasive malignancy, surgery is recommended. And finally, hepatoblastoma. They have increased incidence, though not as high as the other conditions we mentioned. It predominantly occurs in male children less than 5 years of age. As of now, there are no universally endorsed screening recommendations, though in patients with high risk, you can do a periodic liver USG and AFP levels every 3 to 6 months. As far as thyroid cancer is concerned, it occurs in 2% of patients with FAP. And the most common thyroid malignancy to occur in these patients is papillary type of malignancy. It is high occurrence amongst women, so much that almost 90% of thyroid cancers are in women with FAP. So all the females who develop, it is important that other way, you should rule out FAP also. And hence, in these patients, annual USG screening should be started early in teenage years. Finally, to summarize, as far as management of FAP for malignancy is concerned, there should be a regular screening and surveillance for polyps. For colon, prophylactic colectomy with or without proctectomy should be done to prevent CRC. It's important to monitor for extracolonic manifestations. And in this group of patients, genetic counseling for family members is extremely important. And all these patients' relatives, first-degree relatives, should be surveilled for FAP and its manifestations. Thank you very much.
Thank you, Dr. Chetan. Before I hand over to Ram and Deeksha for final 5 minutes, I can see Dr. Deep Goyal. He's also one of the senior surgeons with interest in colorectal surgery. Deep, would you like to make any quick comments or give any specific take-home messages before Deeksha and Ram close?
No, thank you, sir. I think it's an excellent presentation by Dr. Chetan as usual. I think he has summarized it very well. I think the challenge lies in cases where, patient is suffering from active colitis and develops a low rectal cancer. Then the picture gets very confused from the treatment point of view. And I think that is something which we should bring out during our discussion.
So we have 5 minutes because we have a tradition to close at 9. So Deeksha and Ram, any take-home messages, especially for the students?
I have a small question for Dr. Chetan. So,
Yeah.
sir, in a patient with remission, in a ulcerative colitis patient with remission, now you have a left colon cancer. So what will your take for management of this patient? Whether segmental colectomy or still you will like to go for ileal pouch anastomosis?
So basically, if the patient has a dysplasia and he has a left-sided colonic malignancy, so it depends upon if it is above the involving the rectum or it is above the rectum. So if it is above the rectum, I can safely do a total colectomy with ileal pouch and anastomosis. I will not do a segmental colectomy in these patients. However, if it is involving the middle or distal rectum, then I will do what they call it is you do a mucosectomy and hand sewn anastomosis in these patients. I will not do a stapled ileal pouch and anastomosis.
Deeksha, any closing remarks?
So thank you, sir. That was a very comprehensive and a very well-framed talk. I think we'll take the last question, which is there on the YouTube chat box by Dr. Darshan Patel, and I think we will close it at that. So he asks if there are any predictors of a difficult TME.
You can answer, Deeksha. Go ahead.
So I think it makes a lot of difference to understand how a TME is done, the body habitus of the patient, the physiology of the patient, how bulky the tumor is, whether preoperative radiation has been given or not. All of these factors will constitute how was the primary tumor before even giving neoadjuvant therapy. Was it involving the CRM? Were there bulky nodes around it? Has there been a previous pelvic surgery? All of these things make a difference. Also, the definition of a difficult CME will change with time. Sometimes it is difficult to do a CME in a male patient who is either obese or who is very tall, because the pelvic anatomy is very acute and it is difficult to go down into the pelvis, especially if it's a low rectal tumor or a mid rectal tumor. I think with time, all of us learn in our surgical experience to kind of overcome those problems. We learn the nuances of navigating the anatomy from here or there. But I think these are the things that one must keep in mind. An obese patient, a tall male patient with a very narrow pelvis, mid and low rectal tumor, bulky tumors to begin with large lymph nodal masses, and pre-operative radiation.
Also, if I may add, sometimes Deeksha, in these patients who was already, have inflammatory bowel disease for a long time, their mesentery and mesocolon can get shrunken. So it's difficult sometimes to get the colon down to the pelvis. So that also should be kept in mind. You might end up, doing an APR in these patients.
Absolutely, yes, sir.
And a post-hysterectomy female.
Yes, that's very true.
Okay, so I think I have the pleasant duty to thank Ram and Deeksha for agreeing to moderate, and to Sharvari, Chetan, and Sanyukta for presenting. Thank you, Dr. Deep, for joining. Thank you very much. We will
My pleasure,
definitely
my honor, sir.
Hope to see you in one of the future master classes on a topic of your interest.
Sure.
There are a few other senior colleagues who have joined. I would like to thank them. I saw Dr. Banerjee was there, and earlier Dr. Nabeen Podyal had joined from Nepal. And on YouTube, at the moment, we had maximum 35 people watching. But what we have observed that these videos which are uploaded on YouTube by Dr. Avinash Rang's team, they have large number of views. I just saw that the last month masterclass, which was on pancreatoduodenectomy, has already had 350 plus and 400 plus views. And some of the masterclasses are almost touching 1,000 views. So I thank all the colleagues who have contributed to all the master classes. Students, please do join Jaipur Surgical Tutorial. I have already projected Dr. Anand Naga's WhatsApp number. And please email me if you want to read more about CA rectum. I'll be happy to share the chapters on CA rectum from my books on clinical as well as operative surgery. So with that, at 8:59, I will take everybody's permission to close this masterclass. Thank you, everyone. Have a good night.
Thank you.
Thank you.
Thank you,
very
sir.
much.
Thank you,
Good
sir.
night, everybody.
Good
Sweet
night.
Pro. Bye.
Thank you.